Good evening, everyone. I hope all of you are doing well and safe in these testing times. So a very warm welcome to today's program, which is the first of a series of Meet the Professor programs, which we are planning to do over the next 3 to 4 months. So today we will be discussing lymphoma, the controversies and updates in the diagnosis and management of high-grade lymphomas with increased risk of CNS involvement. So it's a great privilege and a great opportunity for all of us to have Professor Fredrick Hagemeister from MD Anderson Cancer Center as the expert for today's program. So a very warm welcome to you, sir. I'm also happy that we have fellows from various institutes across the country to interact with Professor Hagemeister. So the participating centers include the Cancer Institute, Adyar, Kidwai Cancer Institute, Bangalore, Apollo Hospitals, Bangalore, the Ramaya Medical College, Bangalore, Nizam's Institute, Hyderabad, Regional Cancer Center, Trivandrum, Gujarat Cancer Research Institute, JIPMA, Pondicherry, Apollo New Delhi, and Amrita Institute, Kochi. So a warm welcome to all the fellows. I also understand that Hematonc fellows from MD Anderson may be joining today's program. So a special welcome to them as well. So we are really excited to have you as part of the program. So let me quickly take you through the agenda. So the first will be a pre-test in the form of a poll. After the pre-test, we will have the main lecture by Professor Fredrick Hagemeister on the risk of CNS relapse in lymphoma and efficacy of therapy. Subsequently, Dr. Vishwanath, consultant medical oncologist from Apollo Hospitals, Bangalore, will moderate the interaction of the DNB and the DM fellows with Professor Fredrick Hagemeister. And finally, Dr. Santosh Devadas, Associate Professor at Ramaya Medical College Hospitals, Bangalore, will discuss the answers to the pre-test questions and will give the concluding remarks. So this is the disclaimer. So I would like at this point of time to extend our thanks to Natco Pharma for providing us the educational grant as well as the technological support. So quick housekeeping instructions to the attendees. So by default, all the attendees will be on mute and in listen-only mode. So if you want to ask questions, then either you can click on the raise hand option. So then the host will unmute you and then you can ask your question. So the attendees can also choose to ask the questions by typing in the question answer section. So please note that type your questions in the question answer section and not in the chat box. So now we will go into the poll or the pre-test questions. So some instructions regarding the poll. So all the attendees as well as the panelists can participate in the poll. The question with the 4 options, the 4 answer options will appear on your screen and will stay above for about a minute. You have to select the one best option and then click submit. So immediately after the question, the poll result will be announced. So those are not individual results. It's the results for the entire group. So I would request all the attendees and the panelists not to hesitate and then take part in it wholeheartedly. So good luck for the pre-test questions. So I would request everybody to be ready so that we can launch the poll. So now we will go to the main lecture. So on the risk of CNS relapse in lymphoma and efficacy of therapy by Professor Fredrick Hagemeister. So it's my pleasure to introduce him to you. Professor Hagemeister has been associated with the MD Anderson Cancer Center since 1979 and is currently a professor in the Department of Lymphoma Myeloma. His main interests have been the clinical care of patients, education of fellows, nurses, and other trainees, and enrollment of patients on clinical trials. His main interests have been on the management of Hodgkin's and aggressive lymphomas, although he has managed all types of lymphomas throughout his career. So he has several awards and publications to his credit. So in spite of all this eminence, he's a very humble and down-to-earth human being. I had the opportunity to interact with him a few years ago when he had come to Bangalore. He's full of energy, enthusiasm, and a great teacher. So let us listen to him without any further delay. So over to you, Professor Hagemeister.
Okay. Just pulling up a little. There we go. Okay. Well, I really appreciate CPOEM and asking me to start this whole program off. I'm very pleased to be able to talk about this particular topic. Having seen patients like this in the clinic and having tried to make sense out of some of the literature over the last 2 weeks or so and putting together these slides, I can tell you that there's a lot more information that has not been presented or is not being presented by me today. And I'm going to try to cover some of the issues that are still ongoing. I think there are some that have become more clear as time goes on. And it's just a matter of learning what still needs to be learned. First of all, there are 3 different clinical presentations of CNS lymphomas. The first is called primary CNS lymphoma, also which is usually of a non-GCB subtype. It almost never relapses in a systemic fashion. So it's very clear that that is a very different disorder than is secondary CNS lymphoma, which can occur at diagnosis when you have both systemic and CNS disease. Those are very rare cases. And they are often of GCB subtype, and those are the ones that happen to be also double HIT, usually fit into that subgroup. They have a reasonably good prognosis when they receive secondary therapy, as for number 1, when they receive primary CNS lymphoma therapy. And you may find that during some of this presentation that I will refer back to that particular relationship that we often give therapy for secondary CNS lymphoma as if it were primary CNS, using data that we've learned from primary CNS. And then finally, CNS disease at the time of relapse, which is another kind of secondary CNS lymphoma. Those are also abbreviated. You'll see from now on, I'll abbreviate it as CNS-L, which has become a standard format to use and a standard abbreviation for this particular disorder. Those can be either GCB or non-GCB, but they have a very, very poor prognosis, and we need better treatments for them. So this SCNS-L relapse has occurred synchronous with systemic relapse in most cases. Getting isolated disease is very rare, and having leptomeningeal disease as a solitary site is very uncommon. It's usually parenchymal in nature. Relapsed or refractory disease also has a very poor prognosis, which is very different from primary CNS lymphoma, where a significant number of patients can actually be cured of their disorder with modern treatments. We don't understand very much about prognostic factors as yet, and detection of relapse also remains unclear as to how to do it the best way, even though there have been manuscripts that have said that flow cytometry with concentrated CSF and doing PCR might benefit the diagnosis. A therapy for solitary first relapse in this disorder has mimicked that for PCNSL, as I've mentioned before. And the roles of stem cell transplant, radiation therapy, and CAR T are still unclear, although they're better defined for PCNSL, at least the stem cell and radiotherapy are. And new agents are under investigation, and this is a rare disorder making studies difficult. I want to discuss a little bit about primary sites of involvement and specific sites at the high risk of CNS relapse. All of these that I've shown here have been associated with CNS relapse. And it is true that, that renal involvement is now accepted in the CNS-IPI as being the most common site of disease which might indicate a CNS relapse. However, there are other authors who have come up with very different opinions, and testis was for a long time thought to be the most, the disease that's most often associated, but it's not probably, and all of these are in certain circumstances and have been reported to be adverse sites of involvement predicting CNS relapse in the past. Marrow disease was also identified, but large cell lymphoma may have been confused with Burkitt at that time, or lymphoblastic lymphoma in some of those studies, and whether marrow is really involved with CNS relapse is not quite clear. We do know that it is a common feature of double hit, at least in the very beginning, and as many as 40 patients can actually have marrow involvement in some series. More than one extranodal site, however, appears to be accepted as high risk from some of the original studies that were done. There are others who have reported it, but Dr. Van Biezen from our center was one of the first to confirm that number of extranodal sites and a high LDH is all you need to have in order to diagnose or predict CNS relapse. These are specific sites at high risk of CNS relapse, and unfortunately, although some of these have received CNS prophylaxis, and you can see on the left-hand side the number who have this site involved in this particular review of patients who received R-CHOP 21 or R-CHOP 14. The number
Professor, sorry to interrupt you. There is a lot of fluctuation in the sounds here. Yes.
Okay. And so the number with CNS prophylaxis is shown in the middle. And unfortunately, that did not seem to prevent CNS relapse in most of those cases. So it's very difficult at this point in time to figure out exactly what the real risk is of CNS relapse given any particular site of involvement. Although I think now we have to accept that renal is, but notice that I'm going to be, and when I show you the rest of these slides, you'll see that somewhere around 5% to perhaps 6 or 7% in most studies, as low as 3%, is the risk of CNS relapse in patients who are considered to have, quote, high-risk disease. In this study, CNS prophylaxis was at the investigator's discretion. These are results by the progression-free survival by the IPI just for progression-free survival in patients with large cell lymphoma. You'll notice that the R-IPI, which is the revised IPI, which was invented after rituximab became available, that a group that is considered poor risk was identified who approached that level of about 50% survival that we were interested in getting below to identify a poor risk group of patients, but it doesn't hit that. So neither of these particular scoring systems helped very much in helping us figure out whether a patient should receive intrathecal therapy or other kinds of chemotherapy other than R-CHOP. This is a multivariate analysis of prognostic factors in NCCN-IPI. And I just want to point out for the most part that the LDH is split out into 3 different groups, and you get a point for having a high LDH, but if it's over 3 times upper limit of normal, you get 2 points. Age is also split out into 4 different groups. And if you're over 75,
again, the mic is fluctuating, your voice.
Okay. If you are, let's see if just using the screen helps. If you are over the age of 75, you have a much higher risk of developing disease or having more points in this particular system. Specific sites of extranodal disease were each afforded a particular point, and that includes marrow, CNS, liver, or GI tract or lung. Any of those 5 will give you an extra point. So you can have many more than just 5 adverse prognostic features. Notice that number of extranodal sites is not a part of the NCCN-IPI. These are scoring systems that were used to figure out the using the IPI in the NCCN and BCCA cohorts, which were two programs that were used to determine patients. I just want to point out something that I would love you to be able to understand. Look at the low, intermediate, and high intermediate risk groups. Those 5-year overall survivals going this way are very similar between the NCCN-IPI and the IPI. They don't really help that much in helping to make us understand a little bit more about which groups should or should not be treated with higher dose therapy. However, if you get down to the high risk group of patients, you can see that the NCCN-IPI does have a lower or a group that has a higher risk of developing of relapse. And the patients who also they have also relapse as well as overall survival are less in those patients. But it is a smaller number of patients. Only 8% fit into the high-risk group, as opposed to 14% in the high-risk group by the IPI. So are we over-treating or are we under-treating when we use the NCCN-IPI or the regular IPI? I don't know the answer to that. The same that I observed just now is also observed with the BCCA cohort, the patients from Canada. There are other comments about the low-risk patients too, but they all have survivals and progression-free survivals that approach 90% or greater. So I'm not particularly concerned about those patients. I'm more about those high-risk patients and how to better identify them. There was one study that was presented in Clinical Epidemiology, so it's a statistical paper that most of us would not have reviewed. But investigators in this analysis reviewed 46 publications that reported results of 55 different models that have been described for prognosis of diffuse large B-cell lymphoma. And there were issues with these models and that various statistical methods were used. There were small numbers in some studies. Most of them were not validated. And when they were, the IPI, the NCCN-IPI, and the Ara-IPI were used. The NCCN-IPI performed well in most of these studies, however. There were some nomogram studies, a handful, that tended to do better than the NCCN-IPI because they had better discrimination and calibration in their statistics. However, one cannot hold up any of these other analyses and say, this gives me a better idea of who's going to develop progressive disease of diffuse large B-cell lymphoma. For the time being, I think we have to choose the one that we think might be the most easy to use and the most reproducible. I think either the NCCN-IPI or the Ara-IPI, which we don't use very much, are the two that we probably should be using because the IPI was invented prior to rituximab's development. I do want to show you this particular analysis. This is the CNS-IPI. And notice that at the bottom, I've pointed out that extranodal involvement on more than one side is not, I want to repeat that, is not an adverse prognostic factor by hazard ratio in the model. So that although it wasn't an adverse feature, they still included it because they include the IPI as being an adverse feature. And then you throw in this number of extranodal involvement of greater than 1, which is part of the IPI, and kidney or adrenal involvement. So it is a very confusing model, I've got to say, and realize that in the German analysis, both skin and adrenal-renal were both important prognostic features. And in the BCCA group, marrow involvement and there's testis, orbit, and pericardium were also adverse features. However, they chose adrenal-renal because they were the common denominator in both of those studies. That's how adrenal-renal disease was suggested. Notice that for adrenal-renal in this analysis by the Germans, that the involvement was the highest as far as a single site predicting involvement might be concerned. It was also elevated. The risk of CNS by number of factors in both studies was about the same, so there was a good fit. 40 to 60% of the patients, however, are in the intermediate risk group. Understand that, and they may or may not, that's just, notice that that's a low number down at the bottom, may or may not need a CNS prophylaxis. The number is still in the range of 5% or so. So this is, I'm just showing you this again to show you that pretty much everyone has come up with, at least I'll show you the German study, the Canadian study, there's a Danish analysis. Notice that this intermediate group has stayed pretty much the same, and there's a Canadian analysis, I think of show you in a moment. Here, Dr. Puckrin has just presented recently some of their data, and the high-risk patients are all above 10% or so in that range. So this might be a good way of picking out that by using the CNS-IPI, and I think we all use that these days in order to predict which patients have the higher risk, but understand and recognize that it is renal and or adrenal involvement, not testis and not breast and not any of the other sites that we all traditionally know are bad sites of disease, including sinus and marrow and others. This is Dr. El Galali study from European that was published a number of years ago. It was a large number of patients that were looked at for a number.
Dr. Hagemeister, again, it's we're not audible, Dr. Hagemeister.
Let me see.
It's fluctuating.
Do you want to change your mic?
I don't have the mic on. Actually, I'm just using the my screen. Let me pull it a little closer.
Yeah.
Yeah, I think you just be closer to it. That should work.
Okay. Yeah. Okay. So about 15% of these had systemic disease on initial diagnosis, and systemic relapse occurred in 32%. Notice that testis, uterus, renal, adrenal, and an high LDH all independently predicted CNS relapse. And as well, at the bottom, you can see that the curves are fairly similar for those which I showed you before. That's a CNS-IPI. But when you threw in number of extranodal sites, it changed. And this very, very high risk occurred in patients who had 4 or more extranodal sites of involvement. So I think number of extranodal sites seems to make some sense. Exactly where the cutoff is when you're using the CNS-IPI, I don't really know. And it's not a part of the CNS-IPI, except that it happens to occur. It's in the CNS-IPI, but it's not statistically important. Risks after receiving systemic methotrexate, intrathecal methotrexate, or no prophylaxis were all very similar. So in this study, there was no benefit by giving intrathecal therapy or high-dose methotrexate. This is Dr. Klanova's data that showed what the risk of developing CNS relapse was in Goya. And in this trial, those patients who had a high-risk CNS-IPI and had ABC or unclassifiable disease by COO had the highest risk, and that's the red line down there with the risk of 15.2%. The intermediate risk group of patients were those who either had a high CNS-IPI or had ABC or unclassified by a cell of origin. And then the low-risk patients down at the very bottom of those who had neither. Well, that's very helpful. And I think it's something that we might have to consider when we start looking at the CNS-IPI. Realize that at least from the standpoint of doing analyses, this would help us understand a little bit more about how we're able to better select patients, or at least make some sense out of some of the studies that are out there and that have reported results in these patients. This is the outcomes of various different studies that have been reported. I just want to show you this slide only to show you that there have been only really 2 trials, or I should say retrospective analyses, that at that time in 2015 had looked at treatment with therapy other than R-CHOP and whether there was a benefit of R-EPOC or a hyper-CVAD or CODOX-M back. IVAC was not exactly clear at that time until Dr. Oki presented from our center 129 patients, all treated at our center, who were all double hit. CNS involvement was present at diagnosis in 10%, high beta-2 microglobulin in 78%, and a high serum LDH in 69%. So yes, they do have worse features. And at least in our series, about 10% presented with a CNS involvement. CR was achieved in 40% only, and with R-CHOP, 68% with R-EPOC or our hyper-CVAD, which was significant. By multivariate analysis, only adverse performance status and marrow involvement were important, and the CNS disease was predicted by those 2 prognostic factors. And shown on the right-hand side are event-free survival by having none one or those two factors. By multivariate analysis, our epoch was very much superior as far as event-free survival was concerned. Overall survivals were also different, but not statistically so. So our epoch became, at that point in time, considered the regimen to use for patients with double hit lymphomas. This is another analysis that was presented and published at approximately the same time. They were actually reported very much the same time. Ours came out first, and then this one came up. This one was published in Blood. It's a larger group of patients from 23 different centers, not a single center. However, these 4 prognostic factors, advanced disease, leukocytosis, positive CSF, and an LDH greater than 3 times upper limit of normal. I think that's really interesting because you've already seen that before in the NCCN-IPI, that having a high serum LDH was an important prognostic factor, determining whether a patient would develop recurrence. By multivariate analysis, those features were all important, but also which was important was intensive treatment. And you can see on the left-hand side is the progression-free survival with more intensive treatment compared to our CHOP. And on the right-hand side was the overall survival by this model which they developed, which suggested that those patients who had all 4 features had a very, very poor chance of being alive. I think this is a really very valuable particular presentation also because it convinced us at that point that you have to give more intensive therapy other than CHOP for those patients with double hits. This is also a really interesting study which I ran across, which was just published this year. This is looking at patients who had atypical double hits. They're not standard double hits, who have MYC and BCL2 with or without BCL6 rearrangement. Most large cell lymphomas with those rearrangements share a common biology, but atypicals are those that have MYC and BCL2 mutations other than having co-occurring translocations, that is to say copy number variations. On the left-hand side, they're using overall response, or overall risk, I should say, as being, and this is by hazard ratios. You can see that the risk of developing relapse or CNS relapse when you have a translocated, or at the bottom on the left, or your BCL2 is normal, they're using that as a standard. But if you have any gain of BCL2, either minor gain or major gain or going up in the little right, in the circle on the left-hand side, and if you have both translocated, it's very high. And you can see that the hazard ratio goes up significantly. However, if you happen to have translocated BCL2, it doesn't matter what's going on with MYC, whether it's normal gain or gained a lot. Or there's high gains. It's only if they are translocated, both translocated. So what MYC and BCL2 are doing together is very important, but even MYC rearranged by itself with some sort of BCL2 abnormality plays a higher risk in patients developing relapse. I think that's an interesting finding. This is a model score that was also identified 2 groups of patients from 157 patients who are known as double hit signature negative and positive. And this was a double hit signature that was invented by this particular group using various genes to come up with these signatures. And time to progression, overall survival were compared with those with ABC, DLBCL from the British Columbia group treated with R-CHOP. And on the left-hand side, you can see that the time to progression for those patients who have a double hit signature negative did much better. And those patients who had double hit signature positive did approximately the same as those patients who had ABC, DLBCL, not only from the standpoint of time to progression, but also overall survival. They were also compared with another group as well. These are some pathologic and some genetics and pathogenesis of large cell lymphoma. This is one of the questions that was actually asked that you had. There were 574 biopsy samples. There are others that have come up with this MCD analysis and using 372 genes with various methods that are quite technical. 4 different subtypes were identified. Notice that the 5-year overall survival was in fact worse for those patients who had MYD88 and CD79B double mutations. Those patients who had Notch2 mutations or BCL fusion or EZH2 mutation or BCL2 translocation actually did not do very badly. So the MCD happened to do the worst. The Notch1 mutation is a relatively small group. Nonetheless, the correlations are shown at the bottom and may imply therapy, especially for those with the BN2 and the EZB subtype. But MCD double mutation and CD79B is particularly bad. This is a model score also, I'm sorry. So both this LymphGen, this is another study that looked at this MCD analysis with this LymphGen MCD, which you can obtain, as well as a novel hierarchical classification MCD analysis. And they were both prevalent and studied in CNS and systemic relapse. And the results were confirmed in 2 very large cohorts. Shown on the left-hand side are those patients with relapse or systemic disease. Both had disastrous outcomes in this particular analysis from time to progression and overall survival. But what's really interesting is that MCD by either method had a higher risk. You can see with the bar graph, sort of just to the left of the middle, that the risk of CNS relapse was highest in that particular group with the MCD group. I'm not showing you the other analyses, just that one. The others didn't make any difference. Their hierarchical classification MCD consisted of more than three of the other different abnormalities that I showed you here. And I think that's one of the most important takeaways from that particular study. How do you diagnose relapse? I'm not going to even talk about CTs or MRIs or PET scans. I'm going to instead talk about ctDNA because I think that's what's ultimately going to be what will be able to help us make that diagnosis. This is in large cell lymphoma. If you see a 2-log drop in ctDNA following 1 cycle of therapy, the event-free survival in the training cohort and the validation cohort were very, very obvious that having achieved early molecular remission is an important attainment in the peripheral blood for patients who are treated with large cell lymphoma. This is for systemic relapse. This is for CNS relapse. This is 19 patients who've been analyzed by next generation sequencing, MRD status, and it turns out that 2 patients in this analysis had CNS relapse, and both of them had cell-free DNA in the CNS at the time of diagnosis. Both of them received intrathecal prophylaxis, indicating that it didn't help them at all, that the cell-free DNA was the way really to determine that. And I think this is what we're going to have to figure out in the future and make this more of a way to predict these kind of recurrences. What about rituximab as being a therapy for these patients? It, of course, can be given intrathecally, but whether it helps or not is not clear. There was no benefit in the JLS study of the classic R-CHOP versus R-CHOP in CNS relapse noted when patients received rituximab. Rituximab did reduce overall CNS relapse from 6.9 to 4.1% in the Recover 60 trial. In British Columbia, the benefit of R-CHOP was only noted in patients who actually went into complete remission. So there's a lot of distrust on my part. We're giving rituximab to everybody anyway, so what difference does it matter? Other regimens that are more intensive than R-CHOP may reduce CNS relapse, but they have not been proven to reduce it in systemic relapse rates in randomized studies. Realize that there are very few double hits that were enrolled in the R-EPOCH R-CHOP trial. This is prophylaxis using intrathecal methotrexate. I'm not showing you, there's so many studies that have been reported using intrathecal methotrexate, and this is a group of patients, 372, who achieved CR and they had an LDH that was greater than 2 times normal, mass greater than 10 centimeters, performance status greater than 1, or one of those extranodal sites that you're familiar with. 4 doses of intrathecal methotrexate were given after CR. There was an isolated CNS relapse in 11. It was actually a higher CNS relapse rate for those patients who received the intrathecal methotrexate. So that's no way to give the therapy at the end of treatment. An earlier report, this is important because an earlier report from this group did suggest that a lower CNS relapse rate was achievable with giving intrathecal methotrexate. Skin involvement and more than one extranodal site of involvement suggested that you were going to get a CNS relapse. These are studies that have looked at high-dose methotrexate, and again, many different trials or reports of patients. However, most of them are not prospective studies. This includes some patients who are not on prospective studies and some were. You can see that there were different regimens administered. Pay attention to the one at the bottom, the Italian study, which gave only R-CHOP. It was the highest risk group of patients were those patients who received no intravenous methotrexate. And the same is true of their high-risk patients who are in Australia, that those received none had an 18.4% of risk of developing CNS involvement. And high-dose methotrexate and intrathecal brought it down to the lowest. I think it may be that the risk overall is somewhere between 3 and 8% for the average patient. It's just very difficult to tell. And from these studies, it is also difficult to tell whether high-dose methotrexate really does anything or not, because in some studies, it showed some benefit, and at least in these, it did, but there are some that didn't. This was an interesting trial that was reported in 2018. It's a retrospective analysis that was reported in leukemia lymphoma, 480 patients with risk. As you see in the second bullet, the patients received CHOP or R-CHOP-like therapy and at least 2 cycles of high-dose methotrexate. There was no CNS disease at diagnosis, and nobody was over 75. High-dose methotrexate in this study improved systemic progression-free survival and overall survival, but did not prevent CNS relapse. That's exactly the opposite as to what we would think. And when they looked at the different prognostic factors, you can see in the box on the right-hand side that high-dose methotrexate was associated with a lower risk of relapse, but not CNS relapse. So I don't understand that particular outcome. Rituximab was also associated with a lower risk of systemic relapse, of course. So I think it's an interesting observation, and it throws some light onto whether methotrexate really works. So this study also looks at, conducted a multivariate analysis controlling for CNS-IPI, double hit, and testis involvement. And patients were defined from this group in Canada by their own criteria. They have guidelines and their own criteria that were developed. And notice that high-dose methotrexate did absolutely nothing to prevent CNS relapse, progression-free survival, or overall survival in this group of patients. This was published this year. Intensive chemotherapy, likewise, did nothing for those 3 different endpoints. Autologous stem cell transplant did, in particular, it helped with CNS relapse. It also, of course, prevented patients from progressing or having overall survival. But that is a skewed population, a selected group of patients who have to have achieved a CR and don't fail early. So if you do get a patient who is in remission and can get a stem cell transplant, it might be of some value to prevent CNS relapse. But of course, there have been other studies that have suggested only patients with very high-risk disease by IPI should be subjected to stem cell transplant up front. This is also further data from that same group, published last year, showing that prophylactic high-dose methotrexate did nothing to prevent CNS relapse with intensive chemotherapy or auto transplant doing something to prevent CNS relapse. The consolidative auto transplant, there was a difference in this study, but not statistically. This is CNS relapse by CNS-IPI in a paper that was presented at ASH last year. It is not in print yet. Notice, and I'm not showing you all of the things that they showed. These are only serum LDH and number of extranodal sites. I keep coming back to the number of extranodal sites as being adverse. Notice from the curves on the lower hand side that that's the CNS-IPI, and the linear regression for this is 0.01. So it was significant. But look at that moderate intermediate group. It does approach at 5 years or so that risk for those patients who had high risk. Liver involvement and testicular and not renal or adrenal involvement were associated with CNS relapse. The impact of prophylaxis is not clear. This is looking at that matched analysis. Intrathecal prophylaxis made no difference in this group, and intravenous methotrexate made no difference in this group. There are drugs that are known to significantly cross the blood-brain barrier, and they include isofosfamide, which is surprising to me, carboplatin, BCNU, idarubicin, cladribine, and lomustine. So not surprising that BCNU and CCNU are used in autologous stem cell transplant programs. So prior studies of secondary CNS lymphoma reported poor overall survivals. So this was a phase 2 trial that led up to the most recent Marietta study. There were 38 patients who had secondary CNS lymphoma. 16 were at original diagnosis, and 2 patients with systemic involvement received 1 cycle of R-CHOP first. Induction consisted of high-dose Methotrexate-Ara-C, and then they received intensification with cyclophosphamide and Ara-C, and then high-dose etoposide was given for those with systemic involvement. Notice that these patients did not receive any anthracycline. Then they got a transplant, and there was not a bad result. That's all I can say right now at this point. The complete response after induction was 26%. That's really surprising for me. And after the intensification, it goes up to 58%, which is a little bit more understandable because they're giving drugs that work against systemic large cell lymphoma. All 20 patients who underwent stem cell transplant had entered CR and were still free of disease out at 4 or 5 years of follow-up. I think that's very interesting that the overall survivals and event-free survivals were as good as they were in this particular group of patients. So brings us to the Marietta trial, which was just published. This is one of the more interesting and amazing studies that I've seen most recently. It's a phase 2 trial conducted in 24 hospitals in 4 countries. 75 patients were collected. They were run out of Italy. These patients had secondary CNS lymphoma, 32 at original diagnosis, 43 at relapse. 15 of them had isolated CNS relapse. So these were not primary CNS patients unless they had developed recurrent disease. Their features are shown here: more than 1 extranodal site, not CNS, was in 31% of the patients, and having refractory disease in 27%. This is a bad risk group of patients. Patients received 3 cycles of high-dose Methotrexate-Ara-C, and then 3 cycles of RICE, and then BCNU, thiotepa, and a stem cell transplant. I think the most interesting thing about this trial is this is the first time that I have seen patients enrolled at their initial diagnosis separated from those who enrolled at relapse. And you can see on the right-hand side that progression-free survival wasn't very good for those who were enrolled at relapse, but that should be somewhere around 6 months or 8 months that most of those patients would have progressed. So this might be a better analysis, a better method of treatment. I don't know for those particular patients. I do know for those who are initially diagnosed and treated on this program, this is excellent results. And it should be something that we perhaps should adapt in our practice. For those who enrolled at relapse, it's difficult to say that that is much better, but I think it is better. There is certainly going to be a trend for it to be better. I do want to discuss in the last few minutes that I've got, I know I've run over, that this is a study of 45 patients who had refractory relapsed primary CNS or vitreoretinal lymphoma. They did not have systemic disease. They received a R-squared standard R-squared therapy with lenalidomide. The complete response rate after 4 cycles of therapy was 36%. This means that patients should receive lenalidomide perhaps at the time of recurrence, or should have that available as a choice at the time of recurrent disease. Whether it belongs in combination with other therapies is not clear. The progression-free survival was also better for those with a higher CD4, CD8 ratio by using a R-O-C curve. The ibrutinib is also an important drug in the management of these patients. I believe this is a phase 1 study of high-dose methotrexate along with the ibrutinib, and it included 9 primary CNS and 6 secondary CNS lymphomas. 3 out of 6 were newly diagnosed. Overall response rate was 80%, 89% for those with primary CNS and 67% for those with secondary. The median PFS, unfortunately, was 9.2 months, but all 5 who underwent stem cell transplant were NED. And this is also an important study in that they began using ctDNA studies to show responses in these patients. Other drugs that might be important include temozolomide, an old drug that achieved a sort of lower response rate, pemetrexed, which is used in China and has been studied there, temsirolimus, as well as nivolumab. The nivolumab data is real interesting. We have a trial that is ongoing giving nivolumab and ibrutinib together. We've collected 10 patients so far with isolated CNS relapse, and we've seen good responses. We have not completed the trial as yet. So a few comments also about TNF alpha. This is an important cytokine that alters cell-cell adhesion. It increases vascular permeability of the blood-brain barrier, but it is toxic. This particular peptide recognizes CD13, which is upregulated on angiogenic tumor vessels, much greater than normal vessels. So CD13 is found on angiogenic tumor vessels, which are important for keeping those tumors alive. A fusion product of these 2 targets, of these 2 particular things, the peptide and well as TNF alpha, targets tumor vessels and localized drugs to brain and other tumors. 34 patients were enrolled after high-dose methotrexate failure. 12 had failed matrix. 12 of these patients had progressive disease with initial therapy and 19 were considered refractory. Based on this, they began giving this in combination with CHOP. This is the data looking at those patients, and it suggests that you might be able to use this as initial therapy. The overall response rate was 75% and 39% had a CR. CAR Ts are also being used as well, and this was data that's the only one that I know is published. In this study, there were 9 patients who had secondary CNS involvement, and 4 of those patients achieved CR and are still lasting. There was some transient neurotoxicity that occurred in only 1. There was concern about neurotoxicity and confusion with the disease. So the best factor, these are my conclusions, the best factor for CNS relapse is the presence of more than one extranodal site. The CNS-IPI is reasonable to use, but other features also have to be considered, including this LDH greater than 3 times upper limit of normal, specific sites that you might see, as well as double hit. Everybody gets rituximab, so it is really not an issue. Intrathecal prophylaxis, all these drugs may help to clear the CSF, including thiotepa, liposomal Ara-C, and rituximab. But those patients will eventually develop disease progression in the CNS. So I don't expect that they're very good therapies for patients to prevent disease. High-dose therapy is also prophylaxis, has been included in hyper-CVAD, Codax, and other regimens are better at preventing relapse and double hits and might be useful in preventing CNS relapse. We just don't know, but high-dose methotrexate can be incorporated with R-CHOP and EPOCH-R, but its value is also still controversial. So I'm going to say standard treatment for secondary CNS involvement has improved and should include high-dose methotrexate and high-dose. We know that. And consolidation with brain radiation therapy, maybe low dose, and stem cell transplant should be considered. It's still very difficult to prove. Therapy for it remains challenging. Both CNS and systemic treatment is required. Autologous stem cell transplant should be strongly considered for these patients in CR, and whole brain radiation therapy may be useful, and there are novel agents that are being developed. I would be happy to answer questions during the question and answer period that I think Dr. Vish is going to present, has some questions. Thank you.
Yeah. Thank you, Dr. Hagemeister, for that wonderful and insightful talk. I think all of us, including our fellows, have learned a lot from your talk. So let's move on to the next session, the most awaited session, that is the interactive session of the residents and fellows with the professor. Let me make the rules clear. We have 11 residents here, and let's make it 2 minutes per resident. They will ask a question, and Dr. Hagemeister can give an answer which can be within 2 minutes, and then that way we can run through around 11 questions from 11 different residents all over the country. That's the whole idea. So I would like to invite Dr. Shweta, who is from Kidwa Institute of Oncology in Bangalore, to start the first question.
Good evening, sir. That was a very nice talk. Thank you for that. My question would be, is there any evidence for using newer drugs like ibrutinib or like even lenalidomide in frontline, and thus avoiding CNS prophylaxis for high-risk patients?
As far as I know, there is no data that we have seen that is shown. In fact, there's negative data showing that lenalidomide given in combination for patients who have either ABC or GCB type large cell lymphoma doesn't appear to reduce the risk of relapse. Although this American trial has suggested it, and there is an ongoing study that's going to collect a lot more patients to try to sort out which patients those are. I personally think that lenalidomide as maintenance therapy might be useful in some of those patients who have large cell lymphoma for whom you know you're not going to be able to do a stem cell transplant ultimately. I don't know that lenalidomide is good as prophylaxis for those patients up front or in relapse for CNS involvement. I don't think that has been fully worked out. And I just want to preface, I was going to say before the question and answer period began, I did discuss these questions a little bit with Dr. Vish, and I told him, I don't know the answer to any of these questions. And he said, I hope you know some of them. I can give opinions and ideas about it, but from the literature, it's very difficult to tell whether lenalidomide it's useful in treatment. So you would think that it would be useful as far as prophylaxis or as management would be concerned. I would expect more toxicity as far as hematologic toxicity with that regimen. And I wouldn't want to use it in patients who are receiving just CHOP. It has not been tried in combination with more intensive regimens.
Perfect.
What about ibrutinib, sir?
I'm afraid that we don't know yet about ibrutinib either. There has been some concern about patients who have been treated with ibrutinib. There's a regimen called TEDI-R, with the I in TEDI, with the EI on the end, is ibrutinib. And that regimen ended up with a lot of patients developing aspergillosis of the brain, which is really uncommon. No one has seen anything like that. We actually, in our Smart Start trial, used ibrutinib plus lenalidomide as a first-line therapy and saw a really great response in patients who had ABC type of lymphoma after 6 weeks of therapy with this RLI, or R squared, if you want to call it, plus I. Those patients who got treated with just that 6 weeks of that therapy, when in 37% were in complete remission with ABC type of diffuse large B-cell lymphoma prior to any chemotherapy at all. So it's clear that patients who have ABC type, and that's many of those patients who have CNS involvement or secondary CNS involvement will have ABC types. And all of those, almost all of those who have primary CNS lymphoma will have that kind of disorder. And it's interesting because there's a good possibility that ibrutinib could be a useful drug, but you can't get high-dose steroids around that period of time. I think prednisone is okay, but I think high-dose steroids should be avoided because those are the patients who are going to get aspergillosis.
Okay. Thank you, Dr. Shweta and Dr. Hagemeister. I'll move on to the next question by Dr. Ravi Teja from Nizam's Institute of Medical Sciences, Hyderabad.
Good evening, sir. That was a nice talk, sir. So I would like to ask, what are the subsets of DLBCL that would be benefiting from high-dose methotrexate, like double hit lymphoma, triple hit lymphoma, or highly aggressive plasmablastic lymphoma? So should we compulsorily give high-dose methotrexate in those subset or not required?
Well, so I think the more intensive regimens, we don't know which more intensive regimen helps those. You mentioned plasmablastic, and I got to say there's no convincing evidence that if a patient has advanced plasmablastic lymphoma that we're able to do very much for those patients. They may respond to treatment, but that's such a bad risk group of patients. It's not even. It's something else that we have to really work on and try to make some sense out of what better therapy we can administer them. For double hits and other patients, I didn't hear you say double expressors, but those some double expressors fit into that group of high-risk patients and some don't. It depends upon their genetic makeup. And we're just finding out many of these things as time goes on. It's a large list. There are about 300 different genes that are important in diffuse large cell lymphoma, and everybody's got their own ideas. And now we have some that are available. I think once we are able to figure that part out, as far as genetic evaluation or molecular evaluation of those patients who have large cell lymphoma and are able to better figure out what it is as far as their peripheral blood is concerned with cell-free DNA and their CNS. Once we are able to do that, then we can predict which patients will have bad risk of developing relapse and can apply those therapies to that group of patients, because those who are cell-free DNA just have an extraordinarily low risk, regardless of what their disease is. So I'm looking forward to thinking that there would be other studies that are going to be helpful to help us make a decision. As for now, we only have clinical factors to look at. And I would think if you have any of those factors that I mentioned at the end of my presentation, especially 2 or more extranodal sites of involvement, that is, to me and my practice, has been one of the worst features, and it was one of the features that Dr. Van Bezium found out, along with a high serum LDH. And I think serum LDH is actually a continuous variable. So the higher the LDH, the greater the risk. It may have been, it's high in Burkitt lymphoma typically, but these are these high-grade large B-cell lymphomas that don't have just an 814 translocation or an 822 or one of those things that looks a little bit different. So I'm very interested in that particular thing about what patients should receive high-dose methotrexate. I'm fairly convinced intrathecal doesn't. I'm almost convinced that high-dose methotrexate doesn't either. But I think that we have to consider that still for the very high-risk population.
Thank you.
And that means those who have about a 10% risk. That's CNS-IPI, that's high.
Thank you, Dr. Ravi Teja. So moving on to the next question from Dr. Nadeem Ahmed from Cancer Institute, Adyar, Chennai. Dr. Nadeem?
Yes, sir. Good evening, sir. My question to you would be, what dose of IV methotrexate will you consider optimal in cases where we use both IV and IT, though with limited data? What would you consider the optimal dose?
Well, okay. So we don't use, when we're using high-dose methotrexate, we don't usually give intrathecal therapy to those patients as well. I don't think there's any benefit of actually intrathecal methotrexate. It never really made sense to me, although it does clear the CSF, and so do the other drugs that I mentioned, but it doesn't really penetrate the brain. And remember that parenchymal involvement is much more common than is leptomeningeal involvement. So I think that intrathecal doesn't really penetrate this CNS like we would hope it would. Perhaps it's useful as prophylaxis in some patients for leptomeningeal disease, but it doesn't do anything for brain involvement, which is the majority of these. The other point that you mentioned about what are the doses of high-dose methotrexate, it should be at least 3 grams. In our studies here, we do 3.5 grams. There are other programs that have given as high as 8 grams per meter squared. I think when you're giving it in combination with cytarabine, which is the other drug I think you have to give, also cytarabine you have to give in those patients who have active involvement. Realize that cytarabine is a part of hyper-CVAD and Codox-M. So I'm nearly sure or think that both of those drugs should be considered when you've got someone who has secondary CNS lymphoma at diagnosis. How to integrate those drugs into standard R-CHOP therapy or EPOCH-R is much more difficult. And I would say that when we were trying in our analysis and our study that we did of patients who received EPOCH-R, we were able to integrate high-dose methotrexate without difficulty at all. We did not see significant delays. When we did, it really didn't matter. As long as the counts were coming up, we gave high-dose methotrexate 3.5 grams on day 14, 10 to 14 of those patients who were receiving either standard dose-adjusted EPOCH-R or R-CHOP. So it can be done, but again, it may vary greatly from institution to institution as far as tolerability is concerned.
Thank you, Dr. Hagemeister.
Okay, sir.
So let's move on to the next question. This is again from Nizam's Institute of Medical Sciences, Hyderabad. Dr. Deepthi, can you go on with your question?
Sir, thank you for your talk, sir. Sir, my question is, if you are planning for high-dose methotrexate in a case of high-risk patient, is it mandatory that all patients should receive 3 cycles or 2 cycles can be sufficient in any subset?
That's a good question. Probably if you give it early in therapy, it appears that if you give high-dose methotrexate, at least in some studies, if you give it early on, that you do better. And that rather than giving it after you've completed therapy, realizing that the average time that a patient will develop progression in some studies, CNS relapse in some studies, is as early as 6 weeks. So it does occur within a year in the majority of patients, although I have seen patients who have developed CNS relapse at 10 years from diagnosis. And how that happened, I have no idea. How does somebody develop an isolated brain lesion or leptomeningeal involvement at 10 years from having been treated for large cell lymphoma successfully? I don't know how that happens. But the earlier that you give it, the better it would be. In this Marietta trial, realized they gave 2 cycles of R-CHOP, and you could give 3. If the patient was responding and the patient was doing well, you could give 3 doses of therapy. And I think that's just to debug, but that certainly helped treat the systemic involvement. And then with this other higher dose therapy, it's fantastic to do. But the real question here is, does high-dose methotrexate do anything? And I would like to say it does, and I would like to know how to pick those patients out better. But unfortunately, I think all we can do is look at the patient in front of us and try to make an individual decision for that patient.
Thank you, Dr. Deepthi. Moving on to Dr. Mahati from Apollo Hospitals, Bangalore. Can you go ahead with your question, Dr. Mahati?
Sir, I think you've already addressed a part of my question. When in your practice, what is your preferred timing of delivering CNS prophylaxis and that to high-dose methotrexate, and how with the R-CHOP and with the EPOCH-R regimen?
So when we have given it with EPOCH-R, we give it with the first cycle of therapy on day 10. So that's when we start giving the high-dose methotrexate. And in the patients who had systemic involvement and CNS involvement at the very beginning, that was our program, was EPOCH-R along with high-dose methotrexate on day 10. There are other studies that have given less, but we've given as many as 6 cycles because patients received the entire program of EPOCH-R when they had that systemic disease. Some of those went on to get an auto transplant. So it can be incorporated into EPOCH-R, but again, the role of it is controversial. I think if I had a patient these days who was, let's say, 25 years old, a Navy pilot, I've had this patient, a Navy pilot who happened to have hepatic involvement and brain involvement by diffuse large B-cell lymphoma, my treatment option would have been at that time either Hyper-CVET or Codox-M. And because he was younger and I thought capable of taking Codox-M IVAC, that's what he received. And he went into remission and has remained in remission and went back to flying and teaching people how to fly airplanes. That was a single patient, and there are others that we treated similarly. However, Codox-M is awfully difficult to administer. Many of these patients are older. You're not going to be able to do that. So treatment of CNS disease in the elderly, people over 70, it becomes a real question. And most of those patients are eliminated from many of these different trials and retrospective analyses. So exactly how to be able to manage that and when you give the methotrexate, we've given it as early as first cycle and continue to give it that way. We give methotrexate early on and continue doing it that way. We do not give intrathecal therapy unless we're giving some patient who's high risk that we're not sure what the risk is, and we'll give intrathecal, but I don't think that really helps.
Thank you, Dr. Bhati. Moving on to Dr. Sharath Chandra from Apollo Hospitals, New Delhi. Dr. Sharath?
Yes, sir. Hello, Professor Hagemeister. Thank you for that wonderful talk. My question to you is, in lymphomas with high CNS-IPI score and a negative CSF by cytology, is it mandatory to go ahead with flow cytometry also to confirm CNS involvement and choose between CNS prophylaxis versus treatment?
Yeah, I think so. I think so. Yes, surely. Flow in most studies has been better than just cytology, and our cytologists won't do it, won't make a diagnosis unless they have flow that's demonstrated a population, no matter how big, because you can get reactive cells and it can be very difficult sometimes just by cytology. I think that's proven, and many studies just don't even rely on flow. In fact, in the Marietta trial, because it's assumed that those patients have such a high risk of developing CNS involvement or have secondary disease, in the Italian studies, they just give high-dose methotrexate. They just give intrathecal therapy. They don't even do flow cytometry in many of those particular studies now. They don't even do cytologies because they figure they're not helpful. So do we do it? Yes, of course we do. And I think once we get cell-free DNA, that will be something that will have us go back and analyze these patients or reevaluate them and start off with their therapy and do LPs and send it off for some kind of confirmation. And if they're cell-free DNA at the end of treatment, they have a great chance of remaining free of disease. Maybe they don't even need a transplant.
Yeah, thank you, Dr. Sharath. Moving on to the next question, Dr. Sindhu from JITMER, are you there?
Yes, sir.
Yeah.
Good morning, Dr. Hagemeister. Thank you for that wonderful and elaborate, informative talk. I think you have answered most of my questions in your talk and in the previous questions. So basically, as you said, there might be a particular subgroup of patients who need prophylaxis, and we don't know whether it should be high-dose methotrexate or intrathecal methotrexate. They're controversial studies. So with our setting, the problem is, the bed availability and monitoring of the toxicity and stuff. So in such a case, is it okay to go ahead and only give the intrathecal methotrexate, or should we somehow try and incorporate the high-dose methotrexate?
It's a very difficult question to answer. And it's, again, sort of the same things that I've said before. And you're right, the question has been asked in different format or by others. And I tried to allude to it also during my talk. I think it has to be what you're comfortable administering. In many situations, they give triple therapy. So Ara-C, dexamethasone, and methotrexate, thinking that's better. But I don't think there's convincing evidence that giving triple therapy or single therapy, we've done it. We've done all of it. Or that rituximab is better. Rituximab can be done quite easily. And for prevention of leptomeningeal disease, it may be a really good method of doing CNS prophylaxis. But most of those patients realize who have a very high risk, and that's where you have to cut it off. I don't want to say that if you have a risk of less than 5%, you don't want to give everybody high-dose methotrexate. Just can't. And when you start seeing toxicity issues, you have to ask, why do we have that particular problem and how do we prevent that? The biggest toxicity issue that we see is just elevation of liver function studies shortly after the methotrexate's administered. But you know what happens to those on day 5? They come back to normal. So patients resolve the hepatotoxicity that occurs with methotrexate. I will say this, you think about reducing the dose of methotrexate in order to try to prevent toxicity, and you're going down the wrong path. That's not going to help. Going from 3.5 to 2.5 grams, let's say, or to 1 gram, you're now lessening the efficacy of the therapy, and you're also not changing the tolerability because you're just high-dose methotrexate is high-dose methotrexate. Now, you're given 8 grams or something like that. I think that's out of the question. But Methotrexate-Ara-C together as high doses, that's tough. And older patients don't tolerate that. That causes a lot of myelosuppression. So I would say you can't do that unless you're giving it under a controlled environment and it's a young patient. That's the risk. How to pick out those patients who have high risk? I would say if they have a high CNS-IPI, I would be giving methotrexate. And if you can't do that, well, then that's a different story. I don't know that IT does. There are some studies that suggest that it might, okay, but the more recent trials suggest it doesn't. So I don't know.
Yeah, so let's move on to the next question. Dr. Satish Sharma from GCRA Ahmedabad. Can you quickly ask your question, Dr. Satish Sharma? Are you there, Dr. Satish? Okay. If not, let's move on to the next question. Dr. Ishu Gupta from MS Ramaya Hospitals, Bangalore. Can you ask your question, please? Dr. Ishu?
Sir, can you hear me?
Is this is Dr. Satish?
Sir, Dr. Ishu here from...
Yeah, Dr. Ishu, please go ahead.
Thank you for your talk, sir. You have already answered most of the part of my question. You mentioned about the potential role of ctDNA in future. But as of now, sir, what should be our practice of baseline CSF examination in patients with high-grade B-cell lymphomas?
Okay, I'm sorry. What I just missed the last part of your question. I can't hear it very well.
Sir, what should be the baseline practice, like routine practice for baseline CSF examination for the patients with high-grade B-cell lymphomas routinely, sir?
Well, certainly, if you know, I think if you collect flow cytometry and cytology, and you know that they have involvement, that's useful. But I think predominantly on those patients whom we consider high grade, we always get an MRI of the brain to begin with, to start with. That's our standard here. Others might think it's not necessary, but I think it helps us pick out those people who are going to develop progression early on. And many of those studies that said there was early progression, they missed the involvement at the original diagnosis in some of those patients. I don't know how many, but they very likely missed the involvement. I mean, how can you be giving therapy and 2 or 3 weeks later, somebody got CNS involvement? Well, it was there to start with, and it just wasn't picked up. And I think that's why cytology and flow cytometry are not very helpful in a number of patients. And I just can't tell you. I don't know what the real problem is with that, except you can have parenchymal involvement and absolutely a negative flow cytometry. So I don't think that, but I think those two things, looking at CSF and getting an MRI, are both critical. And I think the MRI is the only way to image a patient with CNS or parenchymal brain involvement. You see stuff on it that you don't see on a CT.
Sure.
You haven't talked about PET scans at all. And I think that PET scans are going to be important down the line as well.
Yeah.
So even for the patients with the low CNS-IPI and a high-grade lymphoma, early stage patients, we should go ahead with the MRI at baseline?
I don't know that it's necessary. There is a study that looked at the patients with double HIT, who are typically a bad risk group of people, but they got treated with R-CHOP and radiation therapy because they only had stage 1 and 2 disease, and their results were excellent. And that was published a year or so ago, year and a half. It was at ASH about 2 years ago. A remarkable bit of information and clinical information that if you have very early stage disease, these are people who are 0-1 IPI, you know, and yet have double hits. So not all double hits are really bad double hits. And I'm not sure that you need it if someone has just stage 1 or 2 double hit, or what would be considered that group, high-grade large B-cell lymphoma.
Yeah, thank you. Thank you, Dr. Ishu. Moving on to Dr. Kanika from Kidwai Institute of Oncology. Can you go ahead with your question, Dr. Kanika Sharma?
Hello, sir. Thank you for that informative talk. Sir, I would like to ask, is there any targeted agent with or without systemic therapy that is approved for isolated CNS relapse and high-grade lymphoma?
So no, there isn't, but we've given it. I've given ibrutinib to those patients. I've given lenalidomide to those patients. I haven't personally given any PD-1 inhibitor, but I bet I probably can get it.
Okay.
That I can say. I can probably do that for a patient with relapse disease, and can point to, at least as long as you point to some manuscripts or studies that are ongoing, or things that have been documented about the response, the PD-L1 on tumor cells, and you can document that, that would be the answer. And the CAR-T, we're working on it. I think CAR-T is going to be helpful in those patients.
Like they said that some subsite have a higher PD-L1 expression, like primary mediastinal and primary testicular. So in these subsite, any role of checkpoint inhibitor?
Yeah, also in brain. Also brain has primary brain also has a risk of PD-L1. So it makes some sense that those drugs would work in that setting.
Okay, thank you, Dr. Kanika. Moving on to the last fellow, Dr. Mintu Matthews from RCC Trivandrum.
Good day, sir. My question is, does EBV positive, that I mean in the immunocompetent non-CNS primary EBV positive DLBCL and the CD5 positive DLBCL, do they require any additional CNS prophylaxis than the regular treatment for stage and IPI?
So probably not EBV. There's a lot of question and has been about the value of finding a positive EBR. Some people say it might be important. Some people have said it isn't. I don't know the answer to that. I, however, feel strongly, even though other people think it might not be important, but I think CD5 positivity is important. I think it indicates a much higher risk of relapse. And based on a large series that came from Japan, I think it has a very high risk of developing CNS relapse as well. And I've given R-EPOC and high-dose methotrexate to many of those patients, even a patient, and it may occur with a more, it wasn't evaluated until very recently, and that is testis involvement. Happens to have, I think, a much higher rate of CD5 positivity than other sites might. And that could be a reason why testis involvement is so associated with developing CNS relapse. And we don't know about other sites of involvement. It just hasn't been a regular staining that's been done, or immunohistochemistry hasn't really focused on looking at CD5 in these extranodal sites of involvement. But I suspect that CD5 positivity may account for a common thread. And I have always been, we also have published a paper about CD5 positivity and the higher rate of relapse. Other people have said that it doesn't. BCCA said it wasn't. Sorry, they're wrong. Yeah, it is, at least in our hands. and others have also suggested it as well. So I think C5 carries a higher risk.
Yeah, thank you so much, Dr. Hagemeister. Let's quickly wrap up these questions which have come in this chat box. So this is from Dr. Biswa Prakash Patri, and he's from Guwahati Medical College. His question is, any role of CNS prophylaxis in a case of primary mediastinal B-cell lymphoma in a young female patient?
No.
No, okay. So the next question is from Dr. Jayachandran. He's from Adyar Cancer Institute, Chennai. His question is, there is one patient who has renal involvement in a DLBCL, but the CNS-IPI is low intermediate only. Is there any rationale to give CNS prophylaxis in this patient? If so, how important is renal and adrenal involvement as a single factor for choosing a patient for CNS prophylaxis?
Again, it's the same question about what extranodal sites are involvement are important in predicting recurrence. If you have a low CNS-IPI, as I was making up these slides, I thought, what if you had just a low CNS-IPI but had renal involvement? I wonder if that would fit. I would say, if you've had a patient like that, I'd like to know how you manage that patient, because my guess is that renal involvement as a solitary site is going to be very, very rare. And I don't know how many of those cases occurred in that German trial or that study where they made up the CNS-IPI. I don't know how many of those would have had isolated involvement or involvement of the kidney without having other nodal involvement or more extensive disease. I just don't know. I don't know. And I think that I probably would not consider it as being adverse and would consider it low risk if that was the only site of involvement.
The next question is from Dr. Hussain. He's from Srinagar, Jammu and Kashmir. His suggestion is that most of our patients cannot tolerate sandwiched methotrexate with R-CHOP. Lot of toxicity, and we always get delayed with R-CHOP. Is it better to give CNS prophylaxis early? Can we give IT methotrexate during R-CHOP? And at the end of treatment with 6 cycles of R-CHOP, can we give 2 to 3 cycles of high-dose methotrexate? Looks odd, but is it possible or can it be done?
No, of course, that probably is a standard way that was chosen because it was easier to do than to give more intensive chemotherapy like Codox-M or high-dose methotrexate with under the hyper-CVET program with Methotrexate.Ara-C. I understand the difficulties that one faces, but there are no answers to that question. Apparently, you still end up, I would say that if you end up having at 6 months and you've given intrathecal therapy and the patient received R-CHOP, and now you want to give high-dose methotrexate, you don't have to give high-dose methotrexate because the patient is past the risk of getting CNS involvement.
Yeah.
Or CNS relapse, that I would say. I don't know that you need to give methotrexate afterwards. I don't know that it really prevents anything. It, I think, needs to be given earlier on. And I don't know what the delays mean. If you've got growth factors, I just give growth factors through it. I don't care about it with methotrexate. And methotrexate doesn't cause the problem. It's the R-CHOP that causes problems.
Yeah. I think the next question is by Dr. Sahil Gupta, and you have answered this question during your talk, Dr. Hagemeister. How to choose patients between R-CHOP and high intensity regimens when we have a lack of benefit in overall survival?
Well, okay. So people die of other causes other than their lymphoma. So I wouldn't be surprised that the overall survival, therapy for relapsed lymphoma, relapsed large cell lymphoma, especially systemic disease, it doesn't matter. Those patients have a very poor chance of survival, regardless of what their initial therapy is. If they are refractory, it's dismal. If they have relapse disease, maybe there's a chance with standard stem cell transplant, and maybe CAR-T is better too. But I don't think that overall survival, and I never have, should be considered our major endpoint. I understand that overall survival is the ultimate goal, but progression-free survival which does include survival overall as well as part of its evaluation, is probably still the major endpoint that we should be looking at, not only in indolent lymphomas, not only in aggressive lymphomas, but also indolent lymphomas, mantle cell lymphoma, you name it. If you don't have disease, you can't die of it, if that makes sense. So I just think of it in a very practical way. I know that my patients will die, but I don't want them to die of therapy at the same time as I don't want them to die of disease. And that overall survival will probably include some of those features.
Thank you, Dr. Hagemeister, for that comprehensive discussion. I'm sure our residents and fellows would have learned a lot from this question and answer session. Thank you so much. Now I request Dr. Santosh to take over and wrap up with the detailed answers to the polls. Thank you, Dr. Hagemeister, once again.
Thank you.
Quickly wrap up with quick answers to the questions that were discussed by Lino Jacob. Most of the questions were answered by Professor Fredrick. The first question was on which is the highest risk for CNS relapse among these four options. The answer to that, which many of you got right, is MCL with blastoid histology. Though it looks innocuous that mantle cell lymphoma is a slow-growing disease compared to DLBCL, if there's a blastoid histology, there is a significant risk of relapse, especially CNS relapse. Though the site of involvement like breast or testis is important to suspect a possible CNS relapse, and also the CNS-IPI is very important. It's also important to look at the biology of the disease. For example, a CD5 positive DLBCL, which Dr. Fredrick was referring to, is an important adverse prognostic factor. Similarly, a peripheral T-cell lymphoma, which is aggressive, and an ALK positive ALCL also confer higher risk of a CNS relapse happening. The second question was about the CNS relapses in DLBCL in the post-rituximab era, which is false. So we know that more and more studies have proven that rituximab controls the DLBCL very well systemically, and also has a small amount of CNS penetration, which may reduce the risk of CNS relapse that have been shown in various trials, though it has been debated. At the same time, rituximab is known to delay CNS relapse compared to the pre-rituximab era. However, compared to the pre-rituximab era, when leptomeningeal relapses in DLBCL was predominant site of relapse, the parenchymal relapses have become more common these days. Then that is the right answer for the accept question. When patients relapse, they either relapse systemically or they relapse in the CNS. A combined CNS and systemic relapses are rare. Coming to the third question, CNS relapses in DLBCL mainly occurs within. The answer to this question is 1 year after diagnosis. The median time is even earlier. Median time to CNS relapse is 6 months. Hence, it is very important to identify these high-risk patients and to treat them appropriately. One theory to this is that these patients, because they relapse so early, probably have disease at presentation itself, which was not picked up, and would tend to relapse earlier than later. Question number 4, which of these sites has the highest risk of CNS relapse? Many of you got it right. However, many of you did get it wrong too. Renal site is probably the most high risk for CNS relapse. One has to also remember the other important sites of extranodal disease like breast, testis, epidural site, and uterus in ladies. The next question is, what is the risk of developing CNS relapse in patients with DLBCL with a CNS-IPI of 4? The right answer was 10%, which was discussed during the session. What is important to note that when the CNS-IPI is high risk, the score can be between 4 to 6. If the score is 4, the risk is about 10%. The moment it becomes 5 or 6, there is an exponential increase in the risk, and when the score is 6, the risk of CNS relapse reaches about 35 to 36%. So this is something which is important to remember. Next question was about the biology of the disease, which may predict the risk of CNS relapse. MYD88 mutation and CDKN2A loss are a well-known high-risk prognostic factor in DLBCL. Double hit and triple lymphomas and double expressor lymphomas are also important high-risk prognostic factors. And CD5 positivity. All of this have a higher risk of relapse, especially CNS relapse, one has to remember. And CD44 and cadherin 11 expressions are not very well described in DLBCL. The next question was about workup of patients of DLBCL. MRI is a preferred investigation for CNS imaging of symptomatic DLBCL patients. That is true. This is a except question. False negative results with CSF cytology can reach up to 60% with a single and a small site sample. That is a well-known fact that if you just do a CSF cytology, we are likely to miss occult CSF involvement when compared to doing a highly sensitive 8-color flow cytometry. The next is a CSF flow cytometry is more sensitive than CSF cytology in detecting occult CNS lymphoma. That is true. But in case of a suspected CNS involvement with a negative CSF, there is no point in going and doing a stereotactic brain biopsy, as it may not change our management, and we would anyway treat these patients as a high risk for CNS relapse. The next question was about the dosing of high-dose methotrexate when we use it prophylactically. It is to be remembered that minimum dose of high-dose methotrexate to achieve tumoricidal levels in brain parenchyma is about 1 gram per meter square, and minimal dose of high-dose methotrexate to achieve tumoricidal levels in the CSF is about 3 gram per meter square. If you need to work at both places, you need to give at least 3 gram per meter square to these patients. The last but one question, true about high-dose methotrexate given between R-CHOP chemotherapy. This question is about sandwiching the high-dose methotrexate in between R-CHOP. When you sandwich, there is a lesser risk. This is a true question. So there is a lesser risk of febrile neutropenia than given in the end of treatment. That is false. When you give it as a sandwich, there is slightly higher risk of febrile neutropenia, especially in our our country where the tolerance is poor. Less mucositis is there. That is false. There is more mucositis when you add extra chemotherapy. Better when given within 9 days of delivering R-CHOP. That is also false. Experts recommend that you deliver high-dose methotrexate at day 15 of the R-CHOP when the counts are out by the time recovered, and you deliver R-CHOP by day 15. And the last, which is the right answer, is lesser risk of CNS relapse than end of treatment high-dose methotrexate. This Professor Fredrick was alluding to this. About 20 to 30% of patients have a relapse even before the R-CHOP cycles are over if they are bound to relapse. So it is better to give the high-dose methotrexate as a sandwich rather than end of treatment regimen. The last question was about intrathecal treatment. Most of you got it right. Definitely doxorubicin cannot be used intrathecal and it can be life-threatening, just like vincristine. Rituximab has been used intrathecally even for CNS relapses. Thiotepa and liposomal cytarabine are well-known drugs for intrathecal treatment in hematological malignancies. So I would like to thank one and all, especially Dr. Fredrick Hagemeister for being gracious and being part of this Meet the Professor session. I think it has immensely helped all our postgraduates who have attended and the consultants who were part of this session. I would also like to thank NATCO Pharma for giving educational grant for this meeting. And I would like to thank Venkat, Dhanbal, Sushanta, and Mahesh for the technology support in the background. Thank you, all the attendees and postgraduate. Thank you, one and all. We will end the session, and thanks, Professor Hagemeister.
Thank you very much. I enjoyed our interactions.
Thank you.
Thank you. Thank you so much.
Thank you, sir. Thank you all.